J'ai maintenant l'immense plaisir de vous présenter le professeur Karl Mercieca. Karl, it's a great pleasure to have you with us tonight. Alors, le professeur Karl Mercieca, c'est vraiment un authentique glaucomatologue européen puisqu'il a commencé sa formation à Malte. Il a ensuite fait un fellowship de glaucome à Manchester, au Royaume-Uni, et il est devenu consultant là-bas, consultant spécialisé en glaucome, bien évidemment. Et puis, il a déménagé plus récemment à Bonn, en Allemagne, où il est devenu le chef de service du département de glaucome de l'hôpital universitaire de Bonn. Alors, le professeur Mercieca, il a vraiment une spécialisation dans le traitement chirurgical du glaucome. Il est d'ailleurs à ce titre impliqué dans la task force chirurgie du glaucome de l'EGS. Il est auteur et co-auteur d'une centaine de publications dans le domaine. Et il est également impliqué dans l'EGS pour l'éducation, puisqu'il s'occupe de l'examen de sous-spécialité glaucome de l'EBO. Et il est aussi président du comité des membres de l'EGS qui donc examine les dossiers pour devenir membre, et il est très actif pour l'organisation, et c'est entre autres grâce à lui qu'on doit l'impulsion pour des webinaires partageant les sociétés européennes avec des sociétés nationales. Donc voilà, donc Karl, ce soir, on a le plaisir de t'avoir pour partager ton expérience sur les chirurgies, pour le coup, vraiment invasives dans la prise en charge des glaucomes avancés. Thank you very much, Karl. It's a pleasure to have you. Thank you, Karl.
Thank you very much, Antoine, and thank you all for inviting me, actually. I don't speak French, but I could understand most of what you said, so thank you for the introduction. Can you see my slides?
Perfectly.
Perfect. Okay. So we're talking about advanced glaucoma, and I think Professor Labbe just hit the spot, because one of his first slides showed you that you have advanced glaucoma, and within that you have refractory glaucoma that is uncontrolled. But not all advanced glaucoma is uncontrolled. So the surgery you choose for your advanced glaucoma will depend on how controlled that patient is. And you've just listened to an amazing lecture on how even MIGS might be useful in these patients. So we've been talking about target pressure, target IOP. And this is, of course, very, very important when it comes to this topic, because as Luis Pinto has also said in his really, really amazing lecture, it all depends on how low you need to go. So again, quoting the EGS guidelines, there are various instances where your target pressure should be even lower, perhaps even in the single digits, that is below 10. And one of them, as you can see here, is of course, if your glaucoma is advanced, you probably would like to have a pressure as low as possible. We also, however, don't want to cause harm to our patients, because this is really important, especially many people, even with advanced glaucoma, don't notice that they have a problem, as we saw from the visual fields in Luis's talk. And of course, we also want to avoid having people who, are on multiple drop medications, having loads of problems. So although drops are a very important part of treating glaucoma, when it comes to advanced glaucoma, adding drops, as you can see from this slide here, doesn't necessarily bring you a better outcome. And this is, in my opinion, fantastic work where big studies done on MIGS, where patients were washed out from their drops before having a MIGS device, the Horizon trial, the Compass trial, with over 1,000 eyes. From these trials, what we can clearly see is that the most important effect of a drop is the first drop. So if you start adding a second drop and then a third drop and then a fourth drop, the effect in lowering the pressure is always going to be less and less and less. So if you put one drop, you expect 30% reduction. But if you start adding more, that effect is going to be less. And I'm sure all of you have seen this, where, yes, you have a patient with a field defect, they're on 3 drops, then you do a MIGS and you think that you have, stopped their glaucoma, but they might then end up on a drop again and then 2 drops, and their visual field gets worse. So it's a matter of choosing the right patient. As you've seen, if a patient is controlled, then of course you can do a mix, get them off drops, get their cataract out of the way. But on the other hand, if someone has advanced glaucoma and needs a very low pressure, don't waste time, perhaps, doing mix. I've seen patients in Bonn with 6 eye stents in one eye and advanced glaucoma, who then come to me having 4 drops and Diamox and an advanced field loss. So we now have this explosion of choice, and we've talked about a lot of these options already. So I'm going to go to the side of this graph where we want lower pressure, so more effective pressure lowering, but perhaps we have also more risk. So sometimes we need to take that risk. Professor Labe has already spoken about PreserFlow and Xen. So what about deep sclerectomy and canaloplasty? What about trabeculectomy? What about tubes? Now, of course, trabeculectomy and non-penetrating glaucoma surgery are still the mainstay in advanced cases. Both have about 50 years now of experience, both procedures, loads of publications on these. And of course, if you compare TRABs with non-penetrating surgeries, what all the studies and meta-analysis will tell you, TRABs lower the pressure more. Although if you start adding mitomycin, maybe that difference is not that big. But non-penetrating surgery has less risk of complications like hypotony, choroidal effusions, etc. But of course, we all have our recipes on how to do these surgeries. As we say, there are a million ways to skin a cat. We know that they are effective. There are big papers like this one from James Kerwin in England, showing that the mean IOP after a TRAB at 2 years is around 12. Interestingly, again, we've seen even with bleb-forming devices, you can achieve these pressures, and how large percentages get a pressure reduction of more than 20% and less than 18. But look at the number of post-op interventions as well. I think in France, there's a big culture of non-penetrating surgery. I'm a big fan myself. I do deep sclerectomies regularly. And Nitin Anand, who taught me deep sclerectomy in England, showed also in his papers how powerful non-penetrating surgery, deep sclerectomy, can be. Very similar to the paper on trabeculectomy by James Kerwin. 80% reduction, less than 19 at 3 years. And we have actually just recently published our paper on non-penetrating surgery in the 21st century, actually comparing canaloplasty and deep sclerectomy mainly. And with these procedures, you can also get a mean IOP of 12. DS, deep sclerectomy, seems to give you a more drop-free population, but canaloplasty seems to survive longer. So maybe more on drops, but survival is higher. But the main question for us tonight is what happens when these blebs fail, whether it's a TRAB, a deep sclerectomy, or even a PreserFlow or a Xen. Of course, we can needle, of course, we can revise, and we do so. But if you're looking at blebs like here, top left, or if you have much more complex glaucomas, so sometimes advanced, sometimes maybe not so advanced, but silicone oil in the eye syndrome, congenital glaucomas, neovascular, this is where tubes come in, sometimes even as first line. So tubes, of course, have evolved over the decades now. They've been around for a long time. And the concept is that the drainage of aqueous humor is to the back of the eye. So we don't have anterior blebs anymore because maybe the anterior conjunctiva is scarred. And we want to push fluid at the very back, post-equatorial. And there are really good studies using MRI scans. Luis Pinto also has a study recently published. And we've also shown with, for example, the pole implant, how ultrasound can help you identify how these tubes work. Now, the indications for tubes are many. The commonest for me in Bonn is either trabeculectomies or deep sclerectomies that have failed and maybe have been needled but still failed. Neovascular glaucoma, usually as a primary treatment, or previous retinal surgery, mainly pars plana vitrectomy. But things like uveitis, eye syndrome, conjunctival disease, where you know your pressure flow, your XEN, your trap will scar, aphakic glaucoma, congenital glaucoma, keratoplasty patients, and people who want to wear contact lenses potentially. These are where tubes come in. There are loads of tube studies. I don't want to bore you with tube studies here, but it's already been alluded to. I think Cedric talked about these, and Luis mentioned that the tube versus trap study and the primary tube versus trap study, what they show is that traps work very, very well. But perhaps in eyes that have already had previous surgery, a tube is probably better. So when we're looking at a tube, what do we look for in the perfect tube? Well, there's this concept from Peng, Ko, and Moorfields to have a pressure of 10 with an operation that lasts 10 minutes and an operation that lasts 10 years. And we're far away from achieving that, but slowly we're getting there. We want a tube that has predictable, immediate flow from day one. Ideally, you can titrate the flow. We don't want hypotony because that's our fear with bigger tubes. And we also want, if we're using a tube with a plate, to have a very low bleb profile. So that avoids erosions, perhaps also reduces the risk of double vision. And of course, we are worried about the cornea when we use tubes. So we want a tube that reduces your risk of corneal problems. Now, Ahmed and Barvelt by far have been the most commonly used tubes in the last years. There's no doubt about it. But the dilemma is that the Ahmed, of course, has a valve in it which prevents hypotony. But we know from studies comparing the two that the success rates tend to be lower. They tend to survive less. The Barvelt, of course, is more powerful, but there's no valve, so it's a free-flowing valve. So there are ways we have to do to reduce the flow in the first weeks or days. And of course, we know that there is a higher risk of hypotony with the Barvelt. So another tube which has come on recently is the Paul tube, because size does matter. If you have a lumen which is smaller, much smaller than the Ahmed and Barvelt, if you look at the Paul, the internal lumen is the size or the same size as an eye stent, so 60% smaller lumen, you should have less hypotony. But what's also important is the outer diameter of your tube, because if you have a bigger tube, you have a higher risk of corneal damage. Why? Because we've seen that, and I'll come back to the size, but I'll also show you that the Paul here is very flexible, by the way. But size matters because hypotony is something we dread. We've seen this on the left-hand side, but corneal problems are also something we want to avoid. And if you do enough tubes, you will see corneal problems as the years go by. Of course, you need to place your tube properly. As you can see down at the bottom here, this tube is placed too anteriorly, and with every blink, it's touching the cornea. And this applies to XEN and pressure flow and any structure we place in the eye, any foreign body. But what I meant about the external lumen size, or not external size, the external diameter, I mean, is that if you have a smaller tube, you can place it more posteriorly in the anterior chamber. And that paper by Keith Barton here has shown for Barvelt that if you place your tube behind posterior to Schwalbe's line, your endothelial cell loss is much less than if the tube is placed more anteriorly. So if you have a smaller tube, then it's more likely and more easy to place it posteriorly, especially in eyes where the space is quite limited. So with the Paul tube, the technique is similar to any other tube, and we've published this from my days in Manchester. And just to give you an idea, with tubes, of course, you've got plates, and the tubes need to be secured because we don't want them to move into the eye. You can see that the plate of the Paul is relatively flat here. It's important to stitch it tightly to avoid also movement in various directions. And I won't show you too many videos, but I want to show you how it looks in the eye in the first days post-op. Sometimes if you don't see that blue Prolene stent, which we use for partial occlusion, you wouldn't really know the difference between a Pole tube and the pressor flow. So up at the top, previous trab, this is how it would look in the middle in the first days post-op. So a very nice flat profile. And down at the bottom, you can see a tube in an eye that's had a xen, which you can see now, which has scarred down. It's been revised. Unfortunately, advanced glaucoma, the patient needed, of course, a lower pressure, and a tube here delivered that pressure. Not all tubes are the same. This is a 14-year-old Syrian refugee who had an Ahmed valve implanted. And as you can see, the cornea is scarred. There's a linear scar because the anterior chamber here is quite shallow. The other eye is already blind with 2 Ahmed valves and a completely white cornea. And you can see here that placing a pole, for example, with a smaller diameter has enabled me to lower the pressure to the low teens with no drops at 6 months. Let's see how it goes in a relatively short time. So although tubes are big operations, they're big because they involve many steps. But I don't feel personally that tube surgery is more difficult than, for example, a trab or a deep sclerectomy. And you can see here how the tube fits nicely in the eye. So what about results? Of course, for example, with Paul here, we now have more and more experience. This was the first paper that came out of Manchester showing nice low pressures at 1 year. But we also showed this when I moved to Bonn 4 years ago. I replicated the same results. So it's not just, you know, a one center phenomenon. The same implant in a different hospital by the same surgeon produces exactly the same results at 1 year. So we're having pressures of 12 here, and we have hardly any drops at 1 year. But of course, 1 year is nothing in the lifespan of a glaucoma patient usually. So now, of course, over the years, we're producing more and more. We have 3-year data showing that actually the mean IOP is the same or even better at 3 years. So if your tube works at year 1, it will probably keep on working very well up to year 3. And you can see with the scatter plots here how basically every single patient after a Pole tube in this cohort in Bonn had a pressure lower than the preoperative pressure. And of course, survival curves are always depressing in glaucoma, but you can see that for pressures less than 18, we have relatively good survival curves, although some patients are now back on drops because we keep the Prolene stent in. And I'm very happy to discuss questions after the talk regarding when to pull the Prolene out, because the Prolene ripcord, as we call it, so we place a 6-0 Prolene in this tube to reduce the risk of hypotony in the first weeks. And then after 3 months, we start thinking of removing it if the pressure is not high enough. But as you can see from the bottom left, I've been bitten once where I pulled the Prolene out and we had hypotony and a suprachoroidal hemorrhage. So now we are looking at titrated removal where we don't remove the Prolene straight away, but we only pull a few millimeters and recheck the pressure. And with our ultrasound system, which we're trying to sort of, prospectively analyze better and publish further, you can actually get an idea of when to remove the Prolene and whether it makes a difference. We do have a registry for Pole implants that we set up. This is a European registry, and I'll invite anyone here who's working in Europe and implanting Poles to go on our website, and we'd be very happy for you to join our consortium here. We've just finished recruiting a prospective study comparing Ahmed's versus Pole. Both tubes are very good, by the way, and both give you very good low pressures. But the question is, what happens in a few years' time? Do the endothelial cell counts differ? This is going to be the big question. And to conclude, I've talked about the Pole glaucoma implant. Is it the perfect tube? No, it's not. It definitely isn't. You do have predictable flow, yes, from day one, because we don't tie it like a bar belt. The proline is in, but there's still flow. But we still miss long-term data, 5-year plus data. It's nice to be able to remove the proline like a plan B. I tell my patients always, we can then do something if the pressure rises. It does have a low bleb profile, but we still see double vision because the plate does go underneath the muscles. And I really am convinced and hopeful that it is more cornea friendly. But the future may be titratable tubes. The iWatch is not new. The iWatch has been around for many years. And the iWatch is a tube with a magnet. So you can actually open and close that tube in the first weeks. You can connect it to a Barveld tube, or you can connect it to the iPlate, which is produced by the same company. But there are problems because it's clunky. There are problems because it's a magnet. And I've had a patient have an MRI scan when the tube closed and the patient came to us with a high pressure. So you have to be aware of that. But the future is promising. So there are loads of other tubes coming up. We've got tubes with no plates that drain posteriorly, possibly also into the orbital fat. We've got tubes that can be opened and closed with laser. We've got new materials that are being produced, which are much thinner and slicker. And we've also got automated self-adjustable tubes coming up. So the future is bright. We're going to add more to our armamentarium. It's difficult today to navigate glaucoma because as you've seen from all the talks, there are so many factors that are involved. There are so many choices. Ultimately, I go back to the target pressure that all of my colleagues have mentioned. It depends on what target pressure you want. So not all advanced glaucoma is the same. As Luis Pinto said, unfortunately, people come late to us because they're not diagnosed early enough. It might be that their advanced glaucoma is controllable with something less invasive than a tube or a trabeculectomy. Finally, just talking about pressure flow, bleb forming devices and tubes. When a pressure flow fails, I usually revise it. If the revision fails again, you can try doing this, which is attaching a Barveld or an iPlate, which is a large tube, into the pressure flow to try and save the other quadrants for later surgery. If your pressure flow is still working, like in this case here, there are ways you can do to connect this, but it's not easy. And it's, you can see from the video that it takes a while to get the connection right. You have to dilate your bigger tube because the lumen is actually smaller than the outer diameter of the pressure flow. But this is a procedure that people are starting to do in order not to go directly for a bigger tube, but maintain the advantages of the small pressure flow in the eye and the advantages of a large plate draining post-equatorially further. So to conclude, tubes in general, they are not only for secondary glaucomas, they are like the second line of defense when other things fail. Tubes in terms of aftercare can be quite nice. You don't have to remove the stitches like you do in a trabeculectomy. There's no laser goniopuncture to do. And tubes have become more refined. And with time, we have more data, we have more experience. And also, the more you do, you reduce your operating time. So a Paul tube takes me on average 35 minutes because I use fibrin glue, local anesthesia. So there are ways to become quicker in order to make these operations as slick as possible. So maybe over time, tubes are effective at lowering pressure as they always have been, but maybe that risk is becoming a little bit better. Thank you very much for your attention.
Merci Karl, très belle présentation, très claire, très détaillée. Merci beaucoup, très intéressant.